Welcome to the Physician Associate Podcast.
Hello, welcome to this episode of the Physician Associate Podcast. My name is James. Today I'm joined by Irfan Mehmood. Irfan, do you want to introduce yourself?
So my name is Irfan Mehmood. I'm an Anaesthesia Associate. I qualified in 2010 at Salford in the Northwest. I kind of fell into the role. I did a biomedical science degree and then decided to carry on looking for jobs within the NHS, but not in the labs. And I came across then, as it was known, anaesthesia practitioner role, and it sounded really great. It had physiology, pharmacology, anatomy, all the things I loved at uni. And so it was a kind of natural fit. And so, yeah, that's how I ended up where I am.
So obviously, physician associates and anaesthesia associates, we're often sort of referred to as, sort of sister professions. Can you tell me a little bit about what an anaesthesia associate is, how you describe what the role does?
So we're non-medical providers of anaesthesia. So anaesthetists are doctors trained in the provision of anaesthesia. And in the UK, before AAs, there was only anaesthetists who provided anaesthesia services. AAs are now a new member of the team who provide anaesthesia services. So that includes all aspects of the anaesthetic. So preoperative assessment, the induction, using medicines, insertion laryngeal mask airways, endotracheal tubes, various lines, looking after patients in theatre and waking them up at the end, taking them through to recovery and making sure that their pain and any nausea and vomiting or any other side effects from anaesthetic are well managed and recognised. And we work quite closely with a consultant anaesthetist. And there's probably quite a similarity between PAs and AAs in the sense. So what's different between AAs and PAs is that we have a defined scope of practice on qualification, which I don't believe PAs have. And then the majority of AAs then go on to consolidate their learning and training and expand their scope of practice depending on what the needs are locally in their hospital. So everyone works slightly differently, but virtually everyone has expanded their role since once they qualify.
Okay, thank you. There are a few similarities, aren't there, between PAs and AAs? The training as a physician associate, we are a 2-year postgraduate or master's course for people who have a pre-existing degree in a healthcare science or sort of medical background. Is it the same? Mm-hmm. What are the entrance requirements for anaesthesia associates?
So the entry requirements, I think, are pretty much the same. So you have to have either a biomedical science degree or that kind of background, science degree, or a healthcare professional. So more than half of AAs, I think, currently. It's difficult to know because same as PAs, there's no statutory register. So it's people depend on who replies to surveys and censuses and things. But I think more than half of AAs are from a operating department practitioner or nursing background, with just under half from a science degree background. And so we also undertake a 2-year postgraduate diploma, which some people go on to top up to a full master's. So we have at least 3 days with a certain number of hours, but at least 3 days usually works out to of clinical practice where you're supervised directly by a consultant anaesthetist. So you're getting on-the-job training by a consultant anaesthetist every day you're in work. And then you have learning outcomes that you have to meet for each module with essentially a weekly plan of what you should be covering each week. And then we have MCQs and OSCEs as formal examinations, as well as regular sign-offs by our local clinical lead. And then at the end of 2 years, you should be able to work to the scope of practice, and you can call yourself an AA, recognised by the Royal College of Anaesthetists, and then in future, not so long from now, hopefully, by the GMC.
And we'll pick up on regulation because we're sort of being regulated together, aren't we, PAs and AAs with the GMC. Mm-hmm. In terms of training, am I right in thinking that there's only one university that runs AA training in the UK?
It has been for several years now, just at the University of Birmingham. That's been the HEI. From September, a second provider, UCL, so University College London. So they've already recruited, I can't remember the exact number now, between 6 and 10 trainee AAs. One of the other differences between AAs and PAs is our training. So we don't apply directly to the university to become an AA. We have to apply directly to a trust who advertises, usually on NHS jobs, for a trainee AA, and then the trust employers and enroll on our behalf with the university, with the HEI. So that's, I suppose it's the difference is we're an employee when we're trained.
Oh, I see. So it's sort of earn and learn apprenticeship kind of model.
Yeah. So it's got its pros and cons. I think it's pro. It's a nice way to be trained as the trainee AA, because you're in employment and you're being paid. I think one of the downsides as a workforce issue is that it's a significant outlay for the employer. So they have to invest in 2 years of your salary and your tuition fees. So in terms of an investment for the trust, they have to be able to justify that, and that can be quite challenging for many roles.
Yeah, for sure. And I suppose growing that at scale can be difficult to convince trusts that it's worthwhile doing.
Yeah.
Once you come out, are you, like us, on the agenda for change banding in terms of pay?
Yes. So we come out on Pro Agenda for Change, and there was a job match done several years ago now where we went through the job evaluation process, and it's still, I think it's still on the internet somewhere as a anaesthesia practitioner, and it's banded at band 7. And in terms of banding throughout the UK, it is a little bit variable. Some employers have all their AAs on band 7. Some have all of their AAs at band 8. Quite a few are taking the approach of initially employing at band 7, and with the consolidation of training, learning, and then picking up additional skills and knowledge, and essentially being more useful practitioners, and then move on to a band 8A.
That makes sense, to show progression in the role.
Yeah.
Are most AAs, as a result of that structure, sort of around certain central points in the UK, or are you spread across quite widely, the 4 nations, different cities and rural areas?
So they are quite widespread. I think less so in rural areas. It seems to be more in larger cities, but more and more seem to be cropping up in DGHs. So there's quite a centre, quite a few people in quite a few AAs in and around London. I think the biggest concentration is probably around Birmingham, as there's a number of hospitals there that have trained and then have subsequently merged into one trust. There's quite a few in South Wales, in the northwest we've got quite a few, and around Leeds. Scotland, I think their numbers have been fairly static, but they initially trained quite a few, and they've just restarted training now and advertising for trainee posts. I think Northern Ireland's probably where we have the fewest, and I'm not aware of ongoing training. There's a handful of AAs there.
Right. Okay. And in terms of numbers of AAs in the country, how does that compare against? There might be a few thousand physician associates, 3 or 4. Like
no, so the numbers are significantly different. So best guess is 172 AAs or thereabouts in the workforce based on the last census. We think we've trained closer to 200 plus, but where those AAs have gone and if they're still in employment is difficult to know because there's no statutory register. Mm-hmm. So that's one of the things we've tried to find out. But I think as a group we're much smaller, and I think that's probably a combination of the training structures, as I mentioned, in terms of pay, in terms of training. An individual hospital is limited to how many AAs it can train at any one time. There's only a certain number of operating theatres. There will be trainee anaesthetists that also require training, and when you're initially training, the kinds of lists that you need access to and exposure to are the same, whether you're a junior trainee anaesthetist or a trainee AA. So there's a limit to how many you can train at any one time, and also the fact that AAs only work in and around anaesthesia as opposed to PAs who will work in virtually any specialty.
Sure. Okay. How long has the AA profession been building? Is it similar to the PA profession in that there were a few pilot sites and trials initially, or?
So I started in 2007, and I think I was the 3rd cohort of trainees. So I think the initial cohort were in 2004, the pilot group. Okay. Hopefully, I don't think I'm out by more than a year there. About 2004 was the first cohort, and they essentially helped create the curriculum. So there would have been a draft curriculum, and then they helped set that up. So by the time I started in 2007, there was a finalised curriculum that our education was based on.
Is there a equivalent to the AA profession in other countries? Was it based on, like with PAs, we're based on a sort of model that works in America and has been established for decades? Is there something similar that the AAs were based on, or where did it come from?
So I came across a paper a while ago, and which was the inception of the role, And it involved a delegation essentially from the Royal College and the Department of Health and other stakeholders. And they went and visited a number of countries where they have non-medical providers of anaesthesia. So internationally, nurses provide more anaesthesia in the developing world than doctors, because there just aren't doctors there. So they're known as nurse anaesthetists. And so there's an international federation of nurse anaesthetists. In Europe, there's a few countries which have, it's difficult to say equivalent roles because I don't think they are equivalent, but they have providers of anaesthesia in Italy, non-medical, Italy, Switzerland, Sweden and Denmark, I think. And so some of those sites are visited, but essentially our role is based on a US role. So the anesthesiologist assistant role. There's another role there, again, a nursing one, certified registered nurse anaesthetist, CRNAs. They're a separate role. Their role and kind of scope of practice is a little bit different. The anesthesiologist assistant role, which our role was essentially based on after looking at the various groups, is defined by working in a team model, i.e. a team led by a consultant anaesthetist or the equivalent as they would have in the States. And so that's the basis of our role of working on it as a team working with a consultant anaesthetist, delivering care that the individual AA is competent to deliver. So we've had at the University of the Queen Elizabeth Hospital based in Birmingham, they developed quite close links with some anesthesiologist assistant programs in the States, I believe Florida, and they've had a few cohorts, clearly not during COVID, but before COVID, they had a few cohorts of trainee anesthesiologist assistants who came on electives for a number of months at a time, just to gain experience and see another way of working. So I think Birmingham hosted a few and South Wales hosted a few. And we've actually had a couple of UK trained AAs go and work in the States, although they're quite different roles and you still have to sit the various exams to be recognised in the different countries. There is a precedence for it, and we've had a Canadian trained respiratory therapist come to the UK and work as an AA. So there's not many that have done so, but it is something that has happened, and I expect once we're regulated, it potentially may become more common.
Well, that's exciting. It's nice that you have got that opened up. I think the same might happen for PAs eventually.
Yeah.
Once GMC regulation comes. Was the role established as a result of workplace pressures, workforce demands? Was there fewer anaesthetists and there was work to do? Is that why the AAs were established? It seems to be what most people say the PAs came about from.
So it was similar to physician assistants as they were then. The creation of the role, it was initially known as an anaesthesia practitioner, was investigated and looked at and created due to a perceived shortfall in the consultant anaesthetist workforce compared to demand. And that shortfall has come to fruition. I think the reality is it's come probably later than initially was expected. So I think when the role was created, it didn't match up at that time, particularly with a significant drop in the consultant anaesthetist workforce. But over the last decade, that the supply and demand gap has significantly increased. And in the last census by the Royal College of Anaesthetists in 2020, there was an 8.8% difference between the supply and demand for consultant anaesthetists, which has doubled in the space of 4 or 5 years. So I think now that is starting to bite, and I think on the back of COVID and that significant shortfall and increasing waiting lists, interest in the role and training for the role has increased significantly.
So in terms of your day-to-day work, what might you do on a typical day? What would that look like for you as an AA? So
I think it's quite variable. Again, it depends on where you work and what kind of work you're undertaking. So I work in a major trauma centre. So most of my work involves urgent care. So the trauma list, the CPOD list, it tends to be the mainstay of what I do. I do a lot of regional anaesthesia, and recently we've branched out into essentially a day case facility. So I think it varies quite a bit from trust to trust. A lot of, probably about half of trusts work in something called a 2-to-1 model, where 2 AAs or an AA and a trainee anaesthetist will work in adjacent theatres with one consultant anaesthetist supervising them. And so that was one of the original intentions for the role, was that is how everyone would work. But I think the reality, it doesn't quite match up with that. And people have found other niches and other requirements from their employer. So quite a few are carrying out sedation services, vascular access services, regional anaesthesia services, where I suppose it is kind of in a 2-to-1 model, and as well as working 1-to-1, but in more complex, patient populations or surgeries. So it really is quite a mix of what people are doing.
Okay, excellent. One of the biggest selling points as a physician associate is that we bring an element of continuity into the team. We stay in post. We don't rotate like the junior doctors do across specialties and hospitals. Is that true of AAs as well, is that you become a point of continuity?
I think that's definitely true. And if I'm honest, I didn't initially see it like that. I didn't actually see it on the ground. But having worked in my hospital for nearly 14 years now, including my training, and doing the same kind of lists on a regular basis, that kind of historical memory and institutional memory, you can see the value of it. You know how things work. The scrub teams, your theatre teams know you, the surgical team know you. So even if there's a change of anaesthetist, whether that's consultant anaesthetist or trainee anaesthetist, you're that continuity of, how the system works, where the patients are coming from, where they're going to, what things have to be done to get the process going. So yeah, I say initially I didn't quite see that advantage that people talked about, but as I've done the job longer and longer, the value of that kind of institutional memory is significant, I think.
And in terms of your day-to-day work, obviously you're using anaesthetics. I suppose you're administering medicines. And how do you get around the whole issue around prescribing? Because that's one of the big bugbears as a physician associate.
That is a real bugbear. And the best we've come up with is using patient-specific directives, where a predefined group of medicines is determined and signed off by the consultant anaesthetist to say that this named AA can give this named patient these medicines in the right clinical circumstances. And if I'm perfectly honest, I think that's a less than ideal solution, but we have a limited number of solutions available to us currently as an unregulated profession. And so there's similar to PAs, there's active discussions for increased access to medicines for AAs. Essentially, without medicines, we can't really do our job.
Yeah, of course. It must be even more frustrating for you as an AA than it is for us as PAs. Yeah. How do you think GMC regulation will help the AA?
I think different people have different expectations of it. So I think AAs will expect that it's going to have a significant impact on their working. I think the scope of practice will change with regulation and what we can do. And I think combine that with increased access to medicines, I think the way people work will change. With the faculty of AAs within the Royal College of Anaesthetists, they will help develop that national structure for that role development. What I've been saying to people recently is I think the dynamic's going to change once we're regulated. Instead of being now where essentially your employer, your department, and your supervisor with you will determine what is and is not acceptable practice, what is safe, and on that side of things, I think it'll switch. And I think the same applies to PAs. Of can you, as an individual AA or PA, justify what you are doing? Are you trained and competent and appropriately supervised? And I think there's a lot of AAs and PAs who probably don't think of it like that. And I think people will need to start thinking differently and what regulation means for them in their day-to-day practice. And I think that's a good thing, looking at that. And then the more the rest of the things that people will probably understand from regulation is quite generic and applies to all professionals, whether someone's a doctor, a nurse, or an AA or a PA. Is things like professionalism, maintaining good standards of practice, with good, how you conduct yourself with patients and colleagues, make sure appropriate documentation is in place, appropriate training. So I think all those kind of generic things will come with that and will add value. And I think in particular the area where people probably most struggle is around CPD and continuing that professional development. So I think being regulated will therefore mean that there's a requirement to do that. And I know there's been a whole issue with training recently for junior doctors getting into their training posts. But I think that, yeah, you're right. We do need more people in the workforce. We need more anaesthetists, more AAs. But I think unfortunately there's also a limit on training, good quality training. And so if we overnight doubled the number of anaesthetic trainees, they'd all be competing for the same kind of experiences. And so there's a limit to how many you can put through at any one time, I think. I don't know what that limit is, but yeah, there's a capacity, I think.
And I suppose with COVID having delayed a lot of routine surgeries and the huge backlog pressures now to catch up, it's all hands on deck, really, isn't it? Just whoever can help in whatever capacity.
It is, yeah. So I think over the next 12 months we'll see significant changes in how we work and how we deliver that elective care, which is really built up. And I think it's going to be changing work various people work, using PAs and AAs differently than they have done already. So I think it'll be an interesting time over the next 12 months, particularly as regulation then comes in. I think it'll focus people's minds of how they want to use the different workforce groups that there are.
Absolutely. All right. Thanks, Irfan.
Cool.
If people want to find out more about Anaesthesia Associates, where would you point them to find out more and to get in touch?
So we've got our website. So if you type in Anaesthesia Associates, or the Association of Anaesthesia Associates, then it'll lead you to our website. We've got quite a few resources on there. So we've got videos, give people a bit of introduction to the role. There's various documents, governance documents. I know that's one of the things people often struggle with, about what governance structures should they have in place. We've got job descriptions, so there's quite a lot of resources. And then the Royal College of Anaesthetists have got resources on their website. And the college also hold our voluntary register as a prelude to the statutory register that GMC will hold. So there's lots of resources out there and email contacts. So get in touch if anyone has any questions.
Perfect. Thanks so much for joining me on the podcast. And I hope I'll have you back on in the future to discuss how things have changed. And thanks to you for listening as well. I hope you found that a really interesting conversation. If you've got any ideas for future episodes of the podcast, or you'd like to get in touch with me, I'm on social media at PA Podcast UK. It would be great to hear from you and get you on the show as well to talk about what you're doing as a physician associate. And I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.